I'm Dr. Asim Javed and I'm an interventional cardiologist working at Rawalpindi Institute of Cardiology in Pakistan. This is a series of talks to facilitate learning of image interpretation in coronary intravascular ultrasound.
This technology has been there since 1980s. So two types of catheters. One is a mechanical transducer catheter. The other one is called a phased array or a solid state transducer. To make things easy for you, phased array or solid state transducers are the ones, these are the catheters that are being marketed in Pakistan by Volcano. So Volcano company is giving us Eagle Eye platinum catheters, which are phased array or solid state catheters, whereas the mechanical transducer is the technology that Boston Scientific is marketing in Pakistan. So I think it will be easier for you because some of the centers have Boston machine, the others have Volcano console. So mechanical transducer, if you look at its architecture, there is one transducer. It has a single transducer, the yellow one over here, and it rotates in 360 degrees on the drive shaft and it forms the image. So when it rotates 360 degrees, if you move the IVUS catheter before the 360 rotation is completed, that image will be distorted, and that's called a NURD or a non-uniform rotational distortion. That's an artifact that you get with the mechanical transducers. In comparison, if you look at the solid state transducer or the Volcano transducer, this has 64 stationary transducers. It does not rotate. There is a transducer in all directions, complete 360 degrees is covered. It does not have to rotate. So the NURD artifact does not occur with the Volcano catheter. It only occurs with the Boston catheter. Now the other difference is that there is a small monorail tip for the Boston catheter. So the wire comes out immediately from the tip and it goes out and it passes in front of the transducer. So the IVUS catheter, on the IVUS image, you will see the wire on which the IVUS catheter is going in. So it sees its own wire as well. Whereas with the Volcano IVUS catheter, it's a long monorail system. So the wire goes from the center of the transducers and it's not outside the transducer. So the transducers cannot see their own wire. So on Volcano IVUS imaging, if you see a wire shadow, it has to be a second wire that is in. The first wire on which the catheter was taken in the IVUS catheter, that wire will not be visible in case of Volcano IVUS or solid state transducer. Now looking at the quality of imaging, the resolution, we can see that this is the Boston Scientific catheter. It has 40 megahertz. And the Eagle Eye has 20 megahertz, so the resolution is definitely better here as compared to the Eagle Eye catheter. Now, the other important difference is that in the Eagle Eye, there is a dropout zone right adjacent to the IVUS catheter where you can see nothing. And that's called a ring down area, and you have to remove this ring down artifact. We will discuss that when we come to the artifact talk, but just remember that you can see here 1 to 2 millimeters around the IVUS catheter, it's completely black. You cannot see the vessel architecture or the lumen or anything there. Whereas this ring down does not exist here in this catheter, and you can see the complete details right at, even up to the IVUS catheter. So important differences, both Volcano and Boston have their mechanical or rotational IVUS catheters. So both of them have it, but in Pakistan, iLab is with Boston, which is a mechanical or rotational IVUS catheter. These are smaller diameter, they have good grayscale resolution, but they do need preparation with flushing to avoid air embolism and air artifacts. This does not happen with the Volcano catheters. The NURD artifact may be seen with these short monorail catheters, so they can see their own wire also. They do not require a ring down, and virtual histology and chromoflow technology is not available in this catheter. Whereas in the Eagle Eye Platinum catheter, which is being supplied by Volcano in Pakistan, these are the solid state catheters. These are easier to use, no need to flush. They are They have low resolution in grayscale. They are slightly bulky. They are long monorail catheters and therefore their own wire cannot be seen. They do not have the nerd artifact. The ring down is a must, and virtual and chroma flow capability is present. Chroma flow technology is where the machine is able to actually, imaging is able to show you where the blood tracks. So this is reddish or brownish. You can see it's tracking the blood. So if you see over here, the stents are not well opposed. They are not touching the intima over here. There is a gap between the stent and the intima, so the blood can track between these. And it's very nicely shown here that there is blood not only inside the stent struts, but it's also outside the struts between the intima layer and the stent strut. So this is a good example of malapposition, very easy to detect with this chroma flow technology. But what is important to remember is that a separate IVUS recording has to be done for chroma flow after the grayscale recording. When you do the pullback recording on grayscale, it automatically records the virtual histology, but it does not record chroma flow. If you intend to do chroma flow, you have to take the IVUS catheter back in and do a second pullback recording, and then you get the chroma flow. Now, virtual histology is available in this, again, Volcano IVUS catheter. It's a nice technology which gives you these color maps of all the, it converts the grayscale slices into colored slices, and what these colors represent is green is fibrous, yellow is fibrofatty tissue, white is dense calcium, and red is where you get the necrotic core, and which is more lipid rich core. And we know from the prospect trial that the non-culprit lesions which went on to infarct, they were the ones which had large plaque burden more than 70%, small MLA less than 4 mm square, and thin cap fibroathyroma less than 65 microns. So the Eagle Eye Platinum catheter comes with two sorts of tips. One is a long tip, the other one is a short tip. We luckily acquire the short tip ones because we do know that the IVUS catheter gives an image by looking on the sides. These are not forward looking IVUS catheters. IVUS catheters are still, the technology is to look on the sides. So if you have a long tip, this is a CTO here and that's a branch coming off here. The tip is long enough and the transducer is away from this branch and it cannot actually visualize this branch. But with the short tip IVUS catheter, the transducer can visualize these branches very closely, and so this probably is relatively more useful. And then the deliverability and to go through the tortuosity is also improved with this smaller tip. So that's the difference. The short tip to transducer difference here is 2.5 millimeter, whereas in the long tip it is 10 millimeter distance. And both of these have tip entry profile of 0.019 inch, and they both fit through the 5 French guide catheter.
So this is Eagle Eye IVUS catheter. So all you need to do is, this is how it comes. You just disconnect it here, take off this plastic, make sure it doesn't get wet, and then you hand it over to the person over here and he's going to click it there.
Connected.
Okay. Now let's show it here. So this does not need to be flushed. Okay. So no flushing required for this one. Now all we need to do is just take out this wire and we take it over the normal PCI wire, whichever we have. Flush please. Okay, now we'll show you where to take the IVUS catheter in, and then you have to do the ring down, so which we will show you on the machine. So you need to take this all the way into the left main stem, and once you're in the left main stem, then we will stop with the IVUS center, and then we will record. So now you will see here. Okay, so there we stop now. Now look over there, show it over there on the screen. So that's a ring that we can see. Press the ring down button please.
Ring down.
Okay, good. So now we can take it further.
This is the automated pullback device for Eagle Eye Volcano catheter.
The sterile operator then opens the innermost fold of the bag into which the non-sterile operator places the motor drive. Working together, the operators unfold the bag, extending it to its full length. Begin continuously flushing the imaging catheter with the 3 cc's of saline from the smaller syringe. You'll be flushing twice with the 3 cc syringe on the prep table. Connect the imaging catheter to the motor drive by aligning the dots on the proximal catheter hub and the motor drive unit. And listen for a click, indicating the catheter is fully engaged. Then, when a disposable pullback sled is being used, connect the motor drive to the sled cup, ensuring that the motor drive engages firmly into the sled cup and pierces the sterile bag. Slide the motor drive to the distal-most position so that the catheter's imaging core is as close as possible to the sled nose, and press the catheter's anchor housing into the anchor post located on the sled nose. Press the reset button to zero the LCD. And activate imaging by pressing the imaging button on the motor drive unit. Backload the catheter onto the guide wire and advance the catheter until the guide wire exits the catheter guide wire port. Once you have a clean image, turn the motor drive off and advance the catheter until the distal marker is at least 3 centimeters beyond the region of interest. Activate imaging by pressing the imaging button on the motor drive or on the imaging system. If an automatic pullback device is being used, initiate the pullback by pressing the pullback start button on the motor drive or IVUS system.
So this is a 70-year-old gentleman. This intervention was done at a different hospital, and the patient was then referred to us for rescue. So basically what happened was that they were doing angioplasty of the LAD, and they had a BMW wire in the diagonal. So the diagonal wire was jailed behind the LED stent after deployment, and when they tried to remove the BMW wire, somehow the wire tip broke. So now there is a stent in the LED and there is a wire hanging, BMW wire hanging in the diagonal jailed behind the stent, but the proximal end of the tip is now hanging in the left main stem. So that is what their worry was, that it's hanging in the left main stem, and the family refused surgical removal. You can also appreciate there is some degree of 60-65% disease in the mid LAD. That's still there. Now, we took an 8 French EBU 3.5 through the femoral approach, and we did not have a micro snare at that time, so we used a single loop snare to get hold of this wire. So in order to reduce the friction force and the traction, so what we did was we took a guide liner and we brought the guide liner right up to the stent, and then we thought we will bring in a snare and get hold of the wire, and with the help of this guide liner we will pull it into the guide liner. But at that point we realized that when we tried to enter the snare into the guide liner, the issue is it does not enter the guide liner. Why? Because here you can see that's the guide catheter tip, and you can see my guide liner sitting here in the left main stem there, and that's the distal end of the guide liner, and here within the guide catheter you can see that's the proximal end of the guide liner, and then there is a wire going all the way through the guide catheter and coming out of the guide catheter from the Y connector through which you get hold of the guide liner. Now if you enter the snare into the guide catheter, it does not enter this proximal end of the guide liner blindly. It does not enter the snare. So what you have to do is that you have to preload the snare into the guide catheter, bring it right up to the tip, and then load the guide liner into the guide catheter. So that's what we actually did. But then the problem is you can't have a wire leading the guide liner. So the guide liner with the preloaded snare at the tip is taken into the guide catheter and brought into the left main stem very gently, carefully, without the LED wire leading it. So now you can see once this is there, then we've put in a wire into the LED as well. Now we are trying to snare and trying to get hold of it, and then we managed to get hold of the wire tip, at least it seems like that, and we brought it into the guide liner. But once it comes into the guide liner, there you can see it, the snare lost the tip. We tried this 2-3 times, but every time it brings it into the guide liner but does not manage to keep a hold on it. The knot becomes loose, the grip becomes loose. So what we thought was, now that this tip is into the guide liner, we will bring in a balloon, and then with the balloon we will use it as a trapping balloon, trap this wire end in the guide liner, and then pull the balloon and the guide liner assembly together with this wire trap, and that may bring this gel wire out. So that was the plan. And now in this video you can also see the balloon is entering the guide liner. From here it enters smoothly, but the snare does not enter this point. So you have to be careful even with the balloon going in, the trapping balloon, since it's without a wire, you have to be careful that it goes in through this proximal opening. Now when we were trying to trap the guide liner, we realized on changing views, here you can clearly see that the wire actually is not inside the guide liner. We thought we had brought it into the guide liner tip, but actually it is still hanging in the left main stem, and the snare actually could not bring it into the guide liner. So the trapping balloon thing failed. It's not in the guide liner. Then we thought, okay, let's try to remove this wire by using two wires. So we've taken one wire into the LED, the another wire goes into the circumflex, and then we are twirling the two, because we've taken the distal ends, the proximal ends, we've taken through a single torquer. We passed them through a single torquer, and now we are twisting the two wires over this gel diagonal wire tip, so that we thinking that this might entrap it. All our purpose was to bring this tip somehow into the guide liner, and once it's in the guide liner we will trap it with the balloon and then pull the whole assembly out. So this is what we tried, but it did not succeed. So we do know that with the snare we were able to touch the wire, we were able to move the wire, we could not bring it into the guide liner, but we were able to manipulate the wire with the snare. It does manage to touch it or move it. So we brought in the snare, we are trying to get hold of this wire tip again with the snare, and this time to get more grip, we've also taken a wire into the LED and a wire into the circumflex, and we are going to do the same twisting again. We are going to twist everything together with the snare, the LED wire, the diagonal wire, and then we twist everything and we try to remove all of this together into the guide liner. Again, we'll have to use a trapping balloon to get hold of this wire tip, otherwise the grip is not going to be strong enough. But in any case, this did not succeed. We could not manage to get the tip in, and everything remains the same. So then we thought, okay, let's take a wire and go behind the stent struts and go into this diagonal. The purpose was that we will go behind this into the diagonal, and then we will take a small balloon and balloon behind this stent and create some space to loosen this gel diagonal wire. And then we will take another two wires behind this stent strut with the space made through the balloon into this diagonal, and then we will twirl this gelled wire between these two wires, and then pull the three wires together and bring this into the guide liner. So that was the idea. We took a pilot 50 and we managed to go into this diagonal. But then we tried a 1.25 balloon, we tried a 1 millimeter balloon, and we failed to cross behind the stents. We even inflated the 1 millimeter balloon, and then on every deflation we tried to go behind the stent struts, but the 1 millimeter balloon just could not go behind the stent struts. So this also failed. You can see in the right over here that the 1 millimeter balloon is inflating, and on deflation I try to push it in, but my guide catheter or the guide liner actually goes back uh, and the balloon still fails to go behind the stent struts. So then we decided to do an IVUS to see if IVUS would guide us with any strategy and to see if we had deformed the LED stent in these attempts, because this was also a concern. I did not want to deform the LED stent too much. So the most unexpected thing happened at this point. The moment I took the IVUS catheter in, and as it passed by this proximal wire tip into the LED stent, it took this wire tip into the LED stent. You can see here, this is the gel wire. You can see now the IVUS is coming in, it's touching this wire tip and it's pushing and taken the wire tip from the left main stem into my LED stent. But unfortunately, right at this point in time, the patient started complaining of severe chest pain and became very restless. And in the next image, we can see that the blood flow actually stopped beyond the point where there was a 70% residual disease in mid-LED. Something like a dissection probably took place, because during these efforts our wires did keep coming in and out. So maybe at some point I probably lifted a plaque here, created a dissection. So the patient was very unwell at that time, so we took another pilot 50 wire with the help of a caravel. We crossed the pilot 50 through this point, and then that's the caravel going in. With the caravel there, I removed the pilot 50, took a tip injection to confirm that I was in the true lumen, and now that's the tip injection, so we knew we were in the true lumen. And then next thing, we ballooned this 70% stenosis, we put a mid-LED stent, we dealt with this, and the next thing we thought, this is a good position of the wire. Finally, we've managed to take it out of the left main stem, and with the help of the IVUS, it is now sitting inside the LED stent. So let's sandwich this part of the wire in the LED stent. So that's what I did. I brought in another stent, you can see here, and with this stent, I'm going to sandwich this wire tip between the two LED stents, and the diagonal part we will let it remain hanging in the diagonal. So there you can see, and the stent is being deployed. The diagonal wire is still there, but now there is no more wire here in the LED, and this part of the wire is now being jailed between the two LED stents, and that's the final image. So this is jailed, the stent is up till here, and there is nothing in the left main stem. All clear, that looks good. So I thought, okay, job done. Now we stop at this and we'll just do an IVUS run to see how things look. So that's a finishing IVUS run, and remember, we've only got the LED wire here. That's the LED wire. The circumflex wire has been removed. The single wire on which the IVUS catheter is going in, and this is an eagle eye IVUS catheter, so it does not see its own wire. It only sees a wire if there is a second wire. So in the LED there was no other wire, but when it comes to the left main stem, surprisingly there was the second wire there. So we don't have a wire in the left main stem. How can we see this wire there? So then we realized that the BMW wire had unraveled while they were trying to pull it out. Probably when it broke, we can see the radiopaque part, but there was the unraveled part of the wire also that was still hanging in the left main stem, which we could not see earlier on angiography, but IVUS is showing that wire. So based on this, we decided that the patient needs to remain on lifelong dual antiplatelet therapy. Luckily, this patient has been in follow-up for over 2 years now, and alhamdulillah, he's doing fine, but we plan to keep him on lifelong dual antiplatelet therapy.